And in this picture, the black tube is the ERCP scope, which is the tip of which is positioned just in front of the papilla, which is the bottom of the bile duct, and this is how we access the bile duct to ERCP. And ERCP is useful in extrahepatic cholangiocarcinoma and pancreatic cancer, so narrowing strictures in the bile duct that are either at the hilum of the liver or below. Any intrahepatic cholangiocarcinoma or strictures further up in the liver, we can sometimes access to biopsy, but we can't really offer any useful treatment. But ERCP is very useful at aiding diagnosis and taking biopsies and brushings from the strictures to try and get a definitive diagnosis and allow surgical oncology colleagues to plan the right treatment for a patient. We can relieve jaundice, which is really important because the itch from deep cholestatic jaundice is awful. It affects your appetite, and the patients really become anorexic because their appetite's so poor, and they suffer very severe fatigue. So being able to drain the bile duct is really, really important in most patients with biliary obstruction so that they can go on to have chemotherapy or surgery as safely as possible. So this is the setup we have, and this isn't me obviously, but it's someone wearing a lead apron because it's an X-ray procedure. The white box on a gantry to the left is the X-ray system, and this guy's holding the RCP scope and looking at an X-ray picture on the left and an endoscopic picture on the right. And switching to a different view, this is the papilla, so this is the little opening in the duodenum at the bottom of the bile duct, and that's a catheter in the middle picture that's just been used to make a cut. You can see the white tissue and stretching up where they've done a little cut to make access easier, and on the right is the X-ray picture that's simultaneous with this endoscopic picture. This shows a common hepatic duct stricture, so the black is the X-ray dye we're injecting from the bottom, filling the cystic duct going off to the gallbladder there. This is a stricture, so the absence of the contrast there shows that there's a narrowing, and this is a very swollen biliary tree above. We can use brushes and biopsy forceps to go up into that stricture and take biopsies from it, which, as you know from this morning, is very, very important, increasingly so in planning treatment to get good volumes of tissue for molecular analysis. An additional tool that we've had for about the last 10 years in a useful format is single operator cholangioskopy. So this is a little baby endoscope that actually goes down through the operating channel on our big endoscope, and it's essentially just it's like a Russian doll scenario. It's just the same thing inside, that's miniaturized, that goes down its sort of big mother scope, and we can put biopsy forceps down that. And these are the sort of pictures you can get when you slide this endoscope up the bile duct to a stricture. So you can see neovascularization, which is little new blood vessels. You can see blockage of the duct. You can see extra tissue. This is tumor tissue. You see ulceration. And then these are the biopsy forceps being put on. Under direct vision, you can take targeted biopsies from the stricture. And this really does increase the diagnostic yield of ERCP. So once we've accessed the bile duct and we've taken samples, we then have to put a stent in to hold the bile duct open and allow the jaundice to improve and prevent infection and sepsis, cholangitis, infection of the biliary tree. And we can use plastic stents, which are completely removable, and which is what we tend to do if we're not sure what the diagnosis is and we don't want to put a permanent stent in. Or we can put covered metal stents in, which are removable, but we can't put them across the hilum because they block off the other side of the liver and make the patient very, very sick. Or if we know that there's a malignant diagnosis and we can safely proceed with bare metal stents, which are permanent, we aim to put a bare metal stent into both sides of the liver with a hilar stricture, or just into the bile duct with a distal cholangiocarcinoma or pancreatic cancer. So as I've already mentioned, with hilar cholangiocarcinoma, our target is always to stent both sides of the liver with parallel stents, and this is really important point. So you get this view in the duodenum with two biliary stents coming nicely into the duodenum. You can, if things aren't done correctly, or if things are complicated, because it sometimes just has to happen, end up with stents going through the side of another stent or not quite reaching down to the duodenum. It makes life difficult down the line, because what you want to do is stent optimally, so the patient's jaundice resolves very quickly and they're at low risk of getting cholangitis and sepsis, but you want to be able to access those stents in the medium to long term, because with the chemotherapy, radiotherapy, treatments that are available now, a lot of patients, as you know, surviving longer and longer, and these stents can block. And if you're putting them through the side of each other, or you're ending up with them finishing, 6 centimeters above where we can see them endoscopically, you're very, very limited in what you can do. In this scenario, we can get into either side of the liver, even if these get completely blocked. We can put RFA treatment in to unblock them. We can put new stents in to unblock them and allow the patient to receive more chemotherapy and to live longer. So, as I've already said, optimal drainage is really important, and getting histology is really very important. The opportunities that have been explored over the years around what you can attach to stents are really exciting, but haven't really come to fruition yet. People have tried attaching all sorts of different molecules, drugs to stents to see whether that offers any benefit, because you can see conceptually if this stent is going right through where the cancer is, if you could put something on it that treats the cancer or prevents infection or irradiates the tumour or does something to treat it, it would be very, very appealing. And people have tried that. They've tried antibiotics, they've tried putting things on to stop things sticking to the stent and blocking it. They've tried attaching gemcitabine and sorafenib to the stents. And these things haven't really reached even significant clinical trials. The most well-investigated sort of proposal is using paclitaxel on stents, which has been used in cardiac stents to prevent ingrowth in coronary arteries. And there was a nice but not very, unfortunately, exciting systematic review and meta-analysis of this published last year, which showed that if you do use a paclitaxel-eluting metal stent rather than just a plain non-eluting metal stent, that you do get a little bit of an improvement in stent patency and a slightly more impressive improvement in survival, 267 days versus 218 with the bland stent. So I think that this is still an area of interest and should be explored, but I just don't see the progress that perhaps I was expecting or hoping for when I first talked about this at this meeting about 5 years ago. So one of the things I wanted to talk about today was about complications in ERCP and patient experience, because I think this is something that's been neglected over the years. And it's something that when we speak to our patients about their experience and their pathway of diagnosis and treatment in cholangiocarcinoma, that does, I think, offer us a lot of opportunities to improve. So just to deal with the complications first, ERCP is not without risk. There's a risk of bleeding, of causing a hole in the gullet somewhere, which is around 0.5%, which is pretty standard for any endoscopic procedure. The most common and serious complication of ERCP is frequently pancreatitis, which affects about 5% of people having an ERCP. And this is inflammation in the pancreas gland because we're manipulating the bottom of the bile duct and that passes through the head of pancreas. Another significant complication is infection, and pain during and after the procedure is actually quite common. And the little pictures down the side is a picture of E. coli there. So patients may need blood transfusion. They may need aggressive antibiotics for E. coli infection or other gram-negative infections in the biliary tree. And sometimes the worst-case scenario with these complications is that the patient needs surgery. And very, very sadly, maybe 1 in 1,000 ERCPs that's performed, the patient will die of complications. So it is not a zero-risk procedure. So in terms of patient experience, I think some of the challenges we've got about speed of access and the range of treatments, endoscopic treatments that patients are able to access. And we've been talking a lot in this meeting about equity of access around the country and around different regions. And depending which hospital you end up in, you will probably find there is a very significant degree in terms of promptness of access. If there's only one ERCP list a week, you may wait a full week for your ERCP as opposed to a centre where there's a list every day. You may not have access to the full range of treatments. The provision of pre-procedure information is really quite poor, and the quality of that information that's often provided is not very good, and it's not very accessible to our patients. In my centre, we've been looking at accessibility, and about 50% of our patients, English is not their first language, and we've previously not offered any of this information in any other language. We don't offer large print versions, and we haven't offered audio or video signed information. That's something we're trying to address, and I think it's something that would be ought to be addressed at a national level and in every centre. Consent's really important. Often these procedures are arranged in a rush. Patients arrive, they need to get on with their treatment. They need to be provided with good quality information before they consent, and that consent must not be rushed. I think another quality factor is around sedation, and when we speak to patients that have endoscopies, particularly for hyalocholangiocarcinoma and ERCP, some of the sedation is inadequate. Some of the procedures may take 90 minutes to 2 hours to complete, and having that just with sedation rather than deep sedation or a general anaesthetic is sometimes not appropriate. And I think we need to look at, again, equity of access to adequate sedation so that patients are comfortable during their procedures. The other thing we have to acknowledge is that sometimes the first ERCP will not be the only ERCP, and patients need 2, 3 or 4 procedures to complete the job, and we need to be open with our patients about that. And we also need to be open that sometimes we don't succeed and they will need other procedures, normally percutaneous with the radiologists, to deal with their disease. And then, I know I'm being very negative here, but then talking about some of the challenges we've got in quality of service provision after the procedure's done. A lot of the time, these procedures are being done in a specialist centre, which is remote from the centre where the patient was initially diagnosed, and may be different to the centre where they're going to have their ongoing treatment, whether that's chemotherapy or surgery. And the integration and the communication between those services is often not very good. And I think that, particularly looking around communication of histology results, if we've taken biopsies, the patient expects you to be able to tell them when they're going to get the result. Who's going to give me the result? What's my appointment? When am I going to get the result and know what the next step is? And often the service providing the endoscopy don't actually know that information yet. So making sure everything is as integrated and smooth as possible for patients who are very, very scared, I think is important. So definition of success, I put that on there because our fellows say, they do a case with us, they get a couple of really good stents in, they're really pleased, they think they've done a fantastic job. If that patient had a miserable time beforehand, didn't know what was going to happen to them on the day, was inadequately sedated, then is left drifting after the procedure because they don't know when their follow-up is going to be or what the result of their biopsy is, they will not define that as a successful procedure, even though our fellow does. And I think that's the thing that we have to close that gap between what's a success technically and doing the right thing by the patient technically, but what is a good experience for our patients. So I'll leave those sort of slightly negative things, but I think important things behind, and talk a little bit about EUS now in the diagnosis of cholangiocarcinoma. So you may remember this picture because I've used it before, and it's from my Penguin book of EUS in sort of 1982, but I haven't found a better one yet. So it's a slightly different setup in that we have an ultrasound console, and we have an endoscopic view and a different echo endoscope, which has an ultrasound system built into the tip of it. And this allows us to actually image a very large part of the biliary tree. The right side of the liver is not accessible, but the rest of the biliary tree is accessible from different points in the stomach or duodenum. We can take biopsies using a needle, and that can be either cytology, which is a picture on the right, but we can now, with our better needles, take core biopsies, which are proving very, very useful given the need for molecular analysis now. We can also use EUS to put stents in. This is somewhere there has been, I think, substantial progress over the last 3 years in that we now can use EUS to put stents through the wall of the stomach into the biliary tree and through the wall of the duodenum into the biliary tree, which does allow us a different route of draining the liver, which in some publications to date does not appear to preclude safe surgery thereafter, and seems to have a complication rate that either compares favourably or is even better than ERCP. So I think this is a space to watch. The system that's got the most traction is the Axios system, which is manufactured by Boston Scientific, which is on one catheter with a burning tip. We use this to burn a hole through the duodenal wall, release this internal flange, pull back on the catheter and release this flange inside the duodenum, and it leaves this short, very, very stable stent, which allows drainage of the blocked bile duct straight into the duodenum. And this is something that's got a lot of traction across the world now and is starting to be used in more and more centres. So this just illustrates the insertion of a stent. So use EUS, you put Doppler on to confirm that there's no flow in it, because you definitely don't want to put one of these stents into a big blood vessel. So that's the Doppler being used. This is a needle being used to pass a wire into the bile duct, and then the stent is delivered over the wire and springs open. So in terms of intraductal ablation, so this is sort of the third part of my talk. So these treatments that we can deliver endoscopically to try and damage the cholangiocarcinoma. And the two most used are PDT, so photodynamic therapy, and RFA. Brachytherapy was touched on this morning as part of the Mayo protocol for liver transplantation in cholangiocarcinoma and is very, very sparsely available across Europe, but obviously is used in the US in some centres. So the idea of this ablation therapy is, can we, by burning the tumour or damaging the tumour in some way, improve the duration of the stent that we then place to stop it from blocking? Does it have a direct effect on the tumour? Does it mean that the tumour is more vulnerable to chemotherapy, or it's more vulnerable to the immune system of the patient to damage it? Does it improve the flow of bile through the stent? Does it improve symptoms? And most importantly of all, does it improve survival? And as many in the room will be aware, the evidence has been disappointing over the years. So there was an RCT, the most recent RCT, which actually was this was in abstract form. It's now been published as a paper, I think, in 2018. Was stopped early because, unfortunately, the patients in the PDT group actually did worse than the patients that didn't get PDT. It was slightly controversial, and there are other studies, but none of them are an RCT of the size or bigger than that one that showed a negative effect. So it's still a somewhat controversial technique. This just illustrates what's done. It's a laser fibre. The patient is given a drug that sensitizes the tumour more than the rest of their tissues. Then, under either cholangioscopic or radiographic control, you use a laser fibre to illuminate the stricture, and it damages the tissue, kills the tissue. And as I say, Steve Pereira's data was published in a full manuscript in 2018. It was the biggest RCT of this, and it showed, unfortunately, inferiority in the treatment group. RFA is somewhat more appealing because you don't have to photosensitize the patient, and it's much, much cheaper than PDT and much less cumbersome technically. And this uses radio frequency energy to heat and coagulate tissue. And this is a bit of porcine liver that's heated for these durations, and it just shows the damage. This is a cholangiocarcinoma that has been treated with the Taiwan version. There are two on the market, and you can see, it's obvious, the black and charred tissue. It looks very satisfactory. And you can see this radiographically. This is another obstructive bile duct with a distal stricture. It's been coagulated, and then a stent's been placed. And this is a block stent. So this is the stent, which is white. There's no contrast. This is the very dilated duct above with lots of contrast in it. Coagulation with the RFA catheter. And then when you pull the balloon out and inject dye, you can see it's opened up a nice sort of about 8mm channel in the middle of the stent. So very effective in the immediate appearance, and very easy to use. Again, the data to support it is not great. Certainly there's no evidence that it's dangerous. There's a complication rate with it, but it seems to be within the realms of a typical ERCP. And there are some emerging data, and this unfortunately is the main slide from the paper, but it's actually a really crummy table. But essentially this study here in 2018 was an RCT with 32 in the RFA group and 33 in the control group without RFA. And actually the median survival with RFA was 13.2 months. And without was 8 months. It's not in the table for some reason. And stent patency median was 6.8, and it was 3.4 in the control group. So actually, there is some quite nice data that I wasn't able to present last time I gave this talk, suggesting that actually RFA upfront, before you place the first stent, may actually add some value, which obviously is exciting. And this technology is being adopted, particularly the Taiwan product, is being adopted in a lot of centres around the world, and I hope we'll see bigger studies coming out that actually do demonstrate benefit, but also show us how often we should be doing this. Should we be going back deliberately at timed intervals to retreat with RFA to prolong survival? NICE looked at this, and I think their last update was in 2018. They're worried about the complication rate and the absence of evidence of benefit. So it'll be interesting to see as it's being done regardless around the world, whether emerging data means that NICE are able to shift their position on it. They currently say it should be within a study that it's delivered in the UK. people have compared PDT with radiofrequency ablation, so which is better. I think that's a bit of a tricky comparison when you haven't really proven that either of them are any good on their own. But when they have been compared in a few case series, they've not shown any difference in survival in one of them. But one of them did show overall better survival in PDT, but I think methodologically very weak studies. PDT is extremely expensive. I think the photosensitizer is about 18,000. There's probably someone in the room that knows better than me, about 18,000 per shot in the US, $18,000. So it's very, very substantial cost. But you can get right up into the liver with the PDT catheter, laser catheter, whereas you can't with an RFA catheter. So just to wrap up my talk, around ablation, are there direct or indirect tumour effects? We still don't know. How do we time this with chemotherapy and radiotherapy? Should we be doing repeated treatments? What are the optimal energy levels? We don't know this. So in summary, to end my talk, as usual, doing the basics well is what we emphasise. Imaging and intervention in the correct order. Often patients don't get these tests done in the right order, sometimes with good reason, other times just because of organisational issues. But the correct order is ultrasound and high quality CT before anything interventional is done, before an EUS is done or before an ERCP is done. The reason for that is you're trying to stage a tumour, and if you do something that causes even mild pancreatitis, it messes with the CT appearances and you can't stage the cancer properly. So they can't just come for an EUS or ERCP before they've had their full staging CT. Optimal biliary drainage is essential, and as I said, that's to allow optimal onward treatment by surgical and oncological colleagues. We must minimise complications, and that's about good practice, it's about good processes, and we have to address the patient experience of endoscopy in cholangiocarcinoma because it is suboptimal. We are now, in terms of progress, we are now able to get much better tissue yield and much better volumes of tissue, again, to aid patient treatment. There's still, I think, exciting opportunities about drug-eluting metal stents, and that's still a big space that needs to be filled. EUS-guided bile duct drainage is very exciting. It is expanding, and there is now good data on safety and efficacy. Unfortunately, there probably won't be big RCTs because it's not like a drug trial where that has to happen. Unfortunately, with these sorts of technologies, they tend to just get safety CE marked and then they just get launched and sold. But I think that there is now a body of evidence that suggests these techniques are safe and effective. And still, there's work to be done on proving that these ablative therapies work. But I think there is now a trend in the data available to show that they do. But the exact application where they should fall in the patient's treatment pathway is not clear. So thank you for your attention, and I'm sorry I overrun by a minute.
Thanks very much, Chris.